Well, welcome everyone. I think we'll get started. Thank you so much for taking the time to join us today. My name is Jillian McConnell. I am a knowledge broker with Brain Exchange, and on behalf of my colleagues from the MS Society of Canada, we welcome you and are so pleased that you're able to join us. Before we begin, I want to take a few minutes to just review the technology we will be using this afternoon or this morning, depending on where you are. The audio is provided over the phone, which means if you are hearing my voice, then you're all set, and the visuals or the slides are provided by the online link that you should have received in your connection details so that you can watch the slides as our presenter speaks. On the bottom left of your screen, you will see a blue bubble. If you move your cursor or your mouse over that, you will see Chat with the Presenter. If you click on that, the chat pod should appear. And that's how you can communicate with me during the webinar as well as with the presenter. I do want to make note that only the presenter and I can see your notes in the chat pod, not your fellow participants. And this is also where you can send your questions during the Q&A portion. I want to make you aware that all of the participant lines are muted for this call, and the reason for that is it helps us minimize any background noise or any private conversations that you may be having on the side regarding the talk. If you do need to ask a question or have a concern during the actual presentation, then please use the chat pod as I won't be able to hear you. The presentation itself is being recorded, and within a week or so it will be available both on the MS Society of Canada's website as well as on the Brain Exchange website. So for the purpose of today, those are the only features you need to be familiar with. The webinar is scheduled to be 90 minutes, and our presenter will speak for about 60 minutes or so total, and we will then have the remaining 30 minutes at the end for some question and answer and hopefully some discussion. I do ask that people refrain from asking questions in the chat pod until the end of the discussion, unless, of course, the question is technology related, and then I'll do my best to help you out. Okay, so now that the technical aspects have been taken care of, I want to take the opportunity to review a few bits of information that the MS Society of Canada has asked I share with you on their behalf. The MS Society of Canada wishes to gratefully acknowledge the educational grant received from Biogen, which makes possible this Current Advances in Multiple Sclerosis webinar. The MS Society does not approve, endorse, or recommend any specific product or therapy, but provides information to assist individuals in making their own decisions. Identification of needs, determination of objectives, selection of content and speakers, educational methods, and materials are the sole responsibility of MS staff and advisors. The mission statement of the MS Society is to be a leader in finding a cure for multiple sclerosis and enabling people affected by MS to enhance their quality of life. And now it's my pleasure to introduce our webinar topic and our presenter for today. Today we will be talking about current advances in multiple sclerosis, and we're very pleased to have with us Dr. Michael Namaka with us today to present. At present, Michael Namaka is a tenured full professor at the College of Pharmacy and Medicine in the University of Manitoba. In addition, Dr. Namaka is also cross-appointed as professor in Rehab Medicine and Human Anatomy and Physiology in the College of Medicine at the University of Manitoba and the Winnipeg Regional Health Authority. Michael is also affiliated with the Anesthesia Department of Medicine, where he has an active clinical practice in the Chronic Pain Clinic. Currently, Michael functions as clinician specialized in multiple sclerosis and chronic pain with a recognized cellular expertise in both areas through his professional designation as a neuro-immunologist. These dual profession designations have allowed Michael to bridge his cellular neuro-immunology research to his neurology-based clinical practice. Since his appointment at the university 15 years ago, Michael holds numerous research grants and has published 54 manuscripts, 12 periodicals, 2 book chapters, 1 editorial letter, 65 abstracts, and performed 159 invited presentations worldwide. Dr. Michael Namaka was awarded the prestigious International Commitment to Care Award for his innovative MS research and clinical neurology practice. So we are certainly honored to have with us today Dr. Michael Namaka. And Michael, I will pass it off to you.
Thank you very much, Jillian, for your kind introduction for my talk today. So the purpose of my presentation today is to provide you a comprehensive summary of the underlying pathogenesis of multiple sclerosis. In addition, I plan to demonstrate to you how to apply this key information to better understand treatment management associated with various types of multiple sclerosis that are present. Specifically today, at the end of my webinar, I guess you should be able to understand or have an enhanced understanding of the pathology involved in multiple sclerosis, understand some of the factors that are involved in contributing to this chronic disease, also be more familiar with the diagnostic tests used in the diagnosis of MS, and understanding and describing some of the hallmark clinical presentations that patients with MS suffer, so that we can be in a better position, I guess, to understand the proper classification of the various types of MS that are known to exist. Because then when we put all that together, we're in a much better position to understand the immunomodulatory treatments for MS, which I will predominantly focus on the treatments for relapsing remitting MS and address those. I'll also touch briefly on some of the non-conventional treatment approaches to multiple sclerosis, and also realize that the realistic treatment outcomes, that we don't have a cure for this disease, but it will provide us an update of where we're at in terms of the current treatment strategies that are there to try and alleviate this or wipe out this horrible chronic neurological condition. When we look at the Canadian statistics on multiple sclerosis, we see that MS affects about 1 to 500 to 1 to 1,000 people. That basically extrapolates to 2 to 3 patients diagnosed every single day. So based on the Canadian population of about 31 million people, that means that there are about 30 to 60,000 new MS cases diagnosed every single year. Based on some of the current literature, each patient represents a cost to the healthcare system of about $1.6 million per patient over their life. That extrapolates based on some findings in 2001 to about $1 billion per year Canadian funds. So we can see it's a huge societal and health impact burden that we need to address. And when we look at the contributing factors associated with multiple sclerosis, this is a disease that predominantly affects Caucasian or white females between the ages of 25 to 38 years of age. Again, right after usually people have finished some of their post-secondary studies, getting married, starting to have children, getting on with life. That's the time when the disease often hits. It is predominantly found in females, and I'll address that a little more later. And it has been largely associated, too, with a lot of patients, or in a lot of patients that had other forms of infections, such as Epstein-Barr, human herpes virus 6, chlamydia pneumonia, and others, and I'll explain why that is later in some of my further slides. In addition to infections and gender and age and race, patients that have suffered recent injuries also may be prone to develop multiple sclerosis, as well as I'll touch on the genetics associated with the disease and address whether it is actually hereditary or not. But what's important is to realize the geography associated with the disease, such that if you're less than 15 years of age and you come, for example, to Canada from a low incidence area of MS, for example, like China, if you're less than 15 years of age, you'll be more prone to take on the prevalence rates of MS as a Canadian. But if you're greater than 15 years of age and then you come to Canada, you will retain the lower prevalence rates that you would have had identified in your home country, for example, in this case of China. I'll also touch on diet and sunshine associated with the vitamin D aspects as a potential assisting factor in controlling multiple sclerosis symptoms. Specifically, when we look at the gender aspects, we need to realize that this is a disease that predominantly affects our females. About 3 females per male is the ratio that's currently published knowledge. However, if males do get the disease, in a majority of cases, males will often have a worse or more debilitating course of the disease than a female. Again, with the prevalence age around your more productive years or starting out years, family years between 25 and 35, and again, with race being a significant factor, such that Northern Europeans, Canadians have high risk versus Orientals, for example, as you can see on the extreme right of the slide, have a lower risk for developing MS. When we look at MS and we determine or ask the question, is this a hereditary disease? The bottom line is that it is not a hereditary disease because we have not found a specific gene that we can test that repeatedly can be found to demonstrate that is passed from relative to relative. However, we can say that MS, patients that have MS and their family members have a genetic predisposition to develop MS. And what that really means is if you had a first-degree relative, for example, I have a son and I had MS, that son would, being a first-degree relative, would have about a 5% increased risk than the general population for developing multiple sclerosis, which equates to about a 20 to 40 times increased risk for developing the disease compared to the general population. If I was a twin, however, and my twin had multiple sclerosis, identical twin, that rate would move up to about 30% risk. So all identical twins were one twin that has multiple sclerosis. The second identical twin should definitely be tested. If you're a non-identical twin, your risk goes back to a first-degree relative like a son or daughter of someone with MS that has about a 5% risk, higher risk than the general population of developing it. So it's important to realize that MS is not a hereditary disease, but patients with family members that do have the disease have a genetic predisposition to go on to develop the disease. There are a variety of theories of multiple sclerosis, and the information I'm providing you in this webinar is timely because it's also published in a recent book chapter I put out in Therapeutic Choices that is released. If you take a look into that, you'll see a summary of the slides that are here. But when we look at the variety of theories of multiple sclerosis that initially started as an infectious theory because some of the people were getting certain infections like measles and mumps and rubella that then went on to develop MS. Then other scientists called it molecular mimicry because they thought that maybe some of the proteins released by these infections looked just like the myelin coating that surrounds the nerve axons in the central nervous system that are the ultimate target of the immune system that damage this nerve coating, the myelin coating, interrupting in the normal propagation of electrical impulses, leading to a variety of neurological deficits. As such, it's now accepted widely that MS is an autoimmune disease, an autoimmune meaning that the body's own immune system recognizes some foreign protein. That foreign protein shares a similar look or appearance or homology to that of the protein structure that makes up the normal insulating coating of myelin that we need for propagating our electrical impulses so we can function in our normal daily activities. And unfortunately, our immune system attacks that myelin coating, destroying it, causing a variety of disease-induced symptoms associated with MS. When we look specifically, what you're looking at here at a molecular level, just to simplify it, the blue cell is a T cell up top. The bottom cell that's grayish in appearance is an antigen-presenting cell, which is like a macrophage, monocyte, or dendritic cell. These antigen-presenting cells have a key role in the immune system by basically serving as a filter for your blood. So they are like the filter in your coffee, or they will pick up these foreign antigens, the pink molecule in the middle. It grabs that antigen and it presents it to a T cell above in blue, and when that interaction or binding occurs, that naive T cell becomes activated to an inflammatory Th1 cell to start the pathogenic process associated with myelin destruction of multiple sclerosis, because the pink antigen in the middle shares a similar look or appearance or amino acid sequence to that of the protein structure that is composed of myelin. And I'll walk you through some of that. So once that foreign protein, and that's the mystery of MS, we don't know where this foreign protein comes from that looks like our myelin coating. It could be introduced by genetics, could be introduced by injury, could be introduced by gender or environmental stimuli. But once that foreign protein starts to activate a naive T cell to form the inflammatory Th1 cells here, these Th1 cells start to have lineage expansion, so making, in other words, more and more of these inflammatory Th1 cells that are specifically targeted against that foreign antigen that looks like the protein structure of myelin. So when we think of multiple sclerosis, we have a overall abundance in terms of pathology of these inflammatory Th1 cells directed at an antigen that looks like the myelin coating in our brain and spinal cord. And as these Th1 cells keep proliferating and expanding like cancer cells, we get more and more production of these Th1 cells that ultimately lead to enhanced production of mediators of inflammation such as interferon gamma, tumor necrosis factor alpha, interleukin 2, interleukin 6, and interleukin 12 that continue to drive the lineage expansion and proliferation of more and more of these inflammatory Th1 cells that are like the cancer cells that just keep on growing and growing and growing in a positive feedback cycle, because with every Th1 cell activated, there's more and more mediators of inflammation being produced to continue the positive feedback cycle. So what happens in a very simple schematic that we see here is that in our blood system, we see that Th1 cell gets activated by the antigen that I spoke of. The Th1 cell causes the production of a lot of Th1 cells that are involved in the production of mediators of inflammation. Those mediators of inflammation cause the upregulation of adhesion molecules or sticky molecules at the surface of the blood-brain barrier, which is the entry point into the central nervous system from the outside blood system. These adhesion molecules then allow these Th1 cells that are growing in abundance and numbers in the bloodstream to eventually stick to the blood-brain barrier. Once they stick to the blood-brain barrier, these Th1 cells that are stuck to the blood-brain barrier cause the release of a variety of metalloproteases, and proteases essentially are like the meat tenderizers in a steak. They loosen the integrity of the protein structure of the blood-brain barrier of the endothelial cells, cause opening of gaps that allow these Th1 cells that were activated in the blood to eventually dock at the blood-brain barrier and gain access where they invade into the central nervous system. Once these inflammatory Th1 cells get into the central nervous system, the brain and spinal cord, where we know that MS is a disease where these two areas attack that myelin coating, they are exposed to all this myelin protein that look like the original protein that activated these Th1 cells in the blood. So then these Th1 cells become reactivated in the brain and spinal cord now and start their onslaught of damage to cascade pathways that result in myelin damage of the brain and spinal cord, which are well known to occur in multiple sclerosis. So once these inflammatory Th1 cells get into the brain and spinal cord, Basically, they directly don't cause the damage to the myelin, but they activate macrophages and antibody cells that actually wind up eating away, or they're called phagocytic cells that eat away the coating on the myelin, that therefore interrupts the signal cascade, electrical signal cascade that we need for our normal bodily movements, and it destroys the insulating properties of the myelin coating along our nerve fibers. And what you can see here to visually expand or explain this process, in the top axon you can see a nerve impulse starting here, but it has nice non-broken myelin coating that serves as an insulating coating so that the nerve impulse that we need for our normal bodily function goes from point A to point B, housed inside this encapsulated myelin sheath that allows our body to function normally. However, after an MS attack, a nerve impulse here, we get these holes or lesions or damaged myelin where the nerve impulse that started at point A, some of the impulse is allowed to leave out of these damaged myelin areas, almost like a short in an electrical wire that minimizes the overall percentage of the electrical impulse that gets to the ultimate effector target, hence why people have deficits in sleep, bowel, bladder, and other issues like that. As the disease continues to progress, you can see that the mediators of inflammation released by those inflammatory Th1 cells that get into the central nervous system, the brain and spinal cord, activate those phagocytic cells like antibodies and macrophages that continue to eat away at the myelin coating on the nerve axon, preventing normal electrical nerve impulse transmission, leading to more severe deficits that sometimes we can't recover from, and as such, the disease goes into the progressive stages later on because it's a chronic progressive disorder. When we look at the physical burden of the disease, we see that on average, a median time to acquiring patients from the time they're diagnosed to start to use a cane or a crutch is about 15 years, with the median time to wheelchair confinement being about 25 years. So obviously patients that are diagnosed later in their life with more benign disease will have a better prognostic in terms of time to cane or crutch or wheelchair confinement, and we use that also as a marker of disease progression. When we look at the various treatment options that are here and we are diagnosing our patients with multiple sclerosis, it clearly, this diagram sends a clear message. When you look at the y-axis, which is neurological disability or deficits that a patient would have over time, their lifetime on the x-axis, and the y-axis is a neurological disability, you can see that if we don't treat it all and we have the natural course of the disease, the impact of neurological disability is very high. Patients will have huge accumulation of neurological disability. If a patient is reluctant to start at the time of diagnosis and decides to treat a little later, we can see that we can still significantly reduce the neurological disability at the end course of the disease, which simply means that we have better productive quality of life years with us. But if we do a good job in diagnosing the patients early and getting the patients on board early, we can see that intervention at diagnosis plays a very significant role in reducing the overall lifelong disability that accumulates associated with MS. So the bottom line here is the earlier you treat, the better quality of life long term that you will have. When we look at some of the clinical diagnostic tools that we often use in our patients, we often will draw a cerebral spinal fluid tap or a sample of your cerebral spinal fluid to examine that fluid for the presence of those antibodies like oligoclonal IgG bands. Those are the antibodies that are known to eat away at the myelin coating, for lack of simplicity's sake, that cause the myelin damage. So there shouldn't be those antibodies in your cerebrospinal fluid, but if we do a sample, this is a contributing factor that can assist clinicians to the diagnosis of multiple sclerosis. However, patients often may not like to give a CSF sample because of the fact that they may get some severe headaches associated with the sample once it is obtained. However, in addition to the cerebrospinal fluid tap, we often rely on imaging techniques such as MRI to identify these white spots or lesions. These are the areas that you can see that occur where the myelin has been damaged. What you're looking at in the center on these MRIs is the butterfly structure here. That's the ventricles. And what we do know about multiple sclerosis is that often the lesions on MRI are characteristically show up periventricular, peri meaning around ventricle, obviously around the ventricles, in these white spot type of mannerisms. Also, what we do know about the MRI is that it is at best a secondary indicator of the disease. And because we can't exactly confirm that this white spot on the brain is going to cause this type of clinical deficit, for example, in your speech or in your memory. And as you can see here, people have a variety of different MRIs where they have a lot of lesion activity or white spot activity that's occurring that are here. But often, sometimes an individual like this may not have, despite the lesions, they may not have all the clinical deficits that you would expect to occur with that. So at best, the MRI is known to be a secondary indicator of disease progression that is used to assist clinicians with the cerebrospinal tap to confirm a diagnosis of MS. We also know that we can use the MRI to identify atrophy or the shrinking of our brain over time associated with multiple sclerosis that is also known to occur. So the MRI not only picks up these white spots that help us in diagnosing MS patients, but also shows the shape or integrity of the brain in terms of whether or not there has been this shrinking of the brain, for lack of better words. So this particular slide that we take us to basically is like a summary slide of the pathology. And what we see here is at the very bottom on the y-axis, we have the clinical symptoms, first of all. On the x-axis, we have the time, disease time over the course of a person's lifetime. And the red line in the middle is the clinical threshold by which a patient actually says, I'm not feeling well. They are realizing that something's wrong. What we actually see here by the purple lines that are going up and down, at the very extreme left of the purple line, this is the T cell first getting activated by some foreign antigen protein that looks like myelin coating. When the T cells start to expand and proliferate like cancer cells and get more and more surge of strength, eventually those T cells gain enough strength and enough numbers to cause your first notice of myelin damage that we now know is a first clinical attack where a person says, geez, I can't see or I can't walk. And that period of time, the difference in time here between the left side and the right side of this peak of this purple graph actually is the time, and it's usually each attack will last anywhere from more than 30 days in duration to be considered as a true clinical attack, for example, if you couldn't see. And what you're looking at here is then the person has this first clinical attack, which is called clinically isolated syndrome, your very first attack. And then the symptoms drop below the clinical threshold again, where you don't notice essentially those symptoms and you feel, well, maybe it's just a one-off thing, I'm feeling fine. But as the disease we know continues to progress later on in a period of times, the time between these peaks, which are years, you get a second attack that leads you to go back to see your doctor. And what you can see is that the attack frequency gets closer and closer, such that from the first attack to the second attack that crossed the clinical threshold, it was years. Maybe now between the second attack and the third attack here, it's a matter of months or a year. But the bottom line is that up to this particular point, if you can see my arrow, the person is still recovering fully from that attack because they drop below the clinical threshold so that they feel that they're still okay. And this is the relapsing remitting phase, where you have an attack that crosses the clinical threshold, and then it subsides. We have another attack. It subsides to normal. We have another attack. But then later on, as the disease progresses, we get an attack and we don't recover from that attack. In other words, I always used to recover from a visual problem. Now I'm not recovering from it. I never fully recovered, and I'm left with some permanent deficit that is now called secondary progressive, or the progressive stage of the disease. So as you can see, MS patients can suffer a variety of disease-induced symptoms based on a survey of our MS population here in Winnipeg, as well as other surveys that are consistent with our findings. We can see that patients do suffer a lot of fatigue and weakness, bladder control, pain, depression, etc., difficulty walking due to this debilitating course of the disease. There are several different types of multiple sclerosis, some of which I've slightly alluded to already. The most prevalent type is that relapsing remitting course of the disease, where you have an attack and then you fully recover from the attack as if you're back to normal. Then later on you have another attack and it carries on like that. The good news is that 80 to 85% of all MS cases are the relapsing remitting form of the disease, and that's where a lot of the current treatments that I'll be discussing shortly fall under in terms of focusing the treatments on. Interestingly, 80% of the relapsing remitting group go on to develop, like my previous slide, secondary progressive MS, where they have an attack but they no longer recover from, say, that visual problem. So normally when they were younger, they would always recover back to normal, their vision deficit, but now they have that vision deficit and they're left with some other permanent deficit that never went away. That's secondary progressive. Primary progressive MS is usually, for most part, often seen in males because they have a more debilitating course of the disease. Fortunately, it's only 10% of all MS cases suffer primary progressive MS because this is the form of the disease where you have a deficit, but you never ever recover right from the get-go. It's just the deficits keep coming and they keep accumulating one on the other, and the time to wheelchair and disability is very fast. There's also a fourth type of MS, a predominant type called progressive relapsing, and this is based on one area of your body, like my eye, for example, that used to recover from an attack. Now it's not, based on the example I previously gave. That means that part of the body, my eye, part of it is progressing because I never recovered from it. But if I had a different domain in my body at the same time that was affected, like a foot drag or a drop that MS patients often suffer, that is recovering back to normal. So one domain, my foot, I get an attack and it recovers back to normal, but my eye, I get an attack and I'm not recovering back to normal. That is called progressive relapsing MS, and it's the in-between period between patients that are truly relapsing remitting and those that are truly secondary progressive in nature. So based on my book chapter, what you can see that the treatments right now that are available are predominantly associated for the relapsing remitting course of the disease, and the disease modifying therapies, or DMTs, really are not that effective in terms of primary progressive or secondary progressive forms of multiple sclerosis. In addition to the clinical investigations that I briefly talked on, the MRI and cerebral spinal fluid taps, we also need to make sure that as physicians or as patients, we're aware that we need to get a complete blood count drawn Our liver functions have to be drawn for baseline. We want to check for mediators of inflammation by the ANA, rheumatoid factor, and C-reactive protein. We want to make sure that we're ruling out any thyroid problems by ordering a thyroid stimulating hormone test that can mimic some of the fatigue associated with MS. We want to check our vitamin D levels, vitamin B12 levels, in addition to the MRI and cerebral spinal tap, as well as have our physicians ensure that we do a complete neurological exam looking for neurological deficits that are known to occur due to the destruction of this myelin. But at the end of the day, when we diagnose patients with MS patients have to have at least 2 attacks any time in their life. And each of those attacks have to be separated by each other by at least 30 days in order to be considered as 2 attacks. These 2 attacks any time in their life with a positive MRI that would be done and possibly with a positive cerebral spinal tap can all be used to form a definitive diagnosis of MS. It doesn't require an MRI if we can cull out 2 attacks from our patient visit. But an MRI often is used because, again, as indicated earlier, an MRI is at best a secondary indicator of disease progression because it does not always equate exactly to the lesion location with the lesion deficit that someone may occur due to their MS. However, you can also diagnose relapsing remitting MS with solely an MRI if you're a MRI expert, where they look for certain numbers, types, locations, size of lesions, without finding 2 specific attacks that can occur. So I mentioned both of those because it's important for you to realize how the diagnosis of MS occurs. When we look at clinically isolated syndrome, that's where some people display the characteristic symptoms of MS. They have, however, only 1 attack in their lifetime. With these particular individuals, we often will order an MRI because the MRI in this case, if it shows up with numerous white spots or lesions, as I've shown you in previous examples, then there is a higher probability that people with clinically isolated syndrome will go on to develop full-blown relapsing remitting MS. However, if the patient has an MS-like attack and has a very low or insignificant MRI findings that don't display lesions of any significant nature, those people may never go on to develop MS. So right now, those people that have 1 attack, clinically isolated attack with a very positive MRI should be considered for treatment with the immunomodulatory agents that I'll soon be discussing. However, when we look at drug coverage, for example, in Manitoba and Alberta, I believe the coverage states that you have to have 2 attacks of MS within a 2-year period where each attack is greater or separated from each other by at least 30 days. Now, in my mind, by this time, the disease has progressed way too far. It would be nice if the criteria for drug coverage would say that if people had 2 attacks any time in their life, because we know the disease, these inflammatory T cells are proliferating like cancer, they are building, and if we restrict it to 2 attacks in a 2-year time period, the disease has already progressed to a point that may be more difficult to halt or stop. Versus if we could have treated earlier based on my natural progression slides, we would have had a better outcome for the patient, better quality of life, and would extend their time to permanent disabilities. So I'm hoping for any of you that are out there in terms of drug coverage, insurance companies, that you take note of this particular point when looking at approving the selection of immunomodulatory treatments for relapsing remitting MS, which I will now proceed to go into. One of the first groups, first-line treatments of immunomodulatory agents out there are the interferons and the Copaxone or gluteramine acetate. These are the first-line, front-line agents that run about $20,000 to $25,000 per year per patient per treatment. All of these first-line agents that are to be used or suggested for use in the patient diagnosed with MS are all given by injection, and I will speak to some of the key perils in regards to each of these particular first-line agents and their overall efficacy. All of these agents, when you ask, well, how do they all work? They all work, similar in the effect that they shut down the buildup of these inflammatory Th1 cells that contribute to the myelin damage that I spoke of, and actually promote Th2, which is more an anti-inflammatory or protective role. So they're involved in general to understand the first-line treatments are to shift the balance away of the immune system from inflammatory to anti-inflammatory or back closer to normal. Which one do you pick out of these? Well, it depends on the specific patient. Every patient requires different types of treatments, and there's no one that is really better than the other for these first-line agents, but there are treatment considerations that may be important for your particular patients. When you look at interferon beta 1A, which is the Avonex brand that you may be familiar with, this drug is given by intramuscular injection only once a week. And some people find that very beneficial because they don't have to be treated every day. It gives them no titration, gives them better quality of life in the sense that they're not being injecting every single day. However, like all drugs that are similar in this category, people get flu-like symptoms associated with all the interferons that I'm talking about, so I won't speak of them for all of them, or get the muscle aches, headache, fever, malaise, chills, things like that. But the good news is that those type of flu-like symptoms, you develop tolerance over time. We also, because these drugs like Avonex and the interferon products are excreted and metabolized through the liver, we have to make sure that we're following liver function tests to make sure that the drug isn't hurting our liver. We're watching for injection site reactions because we're giving an intramuscular injection of the drug, of this protein, again, into our body. But one thing I wanted to touch on here is that this particular product has a low incidence of neutralizing antibodies. And neutralizing antibodies are antibodies that are produced by our own body to negate the beneficial effects of the drug that we're injecting into our body. Now, interferons are a protein. Our body, if we have MS, has already an overactive immune system. So when we're injecting a foreign protein into our body again, it would make sense the body's trying to counteract the effects of that protein, even though in this case, the interferon beta 1A Avonex is a good thing because it's the drug. The good news is that the neutralizing antibody production is only 2 to 5% with this particular interferon, which means that not too many people's own body will reject the use of this drug, so it can work beneficially. When we look at the efficacy of these drugs, they're about 30% effective, which essentially means that's based on annualized relapse rate reduction, which essentially means that if the disease had 10 shells to shoot at you, by taking the drug early, you only are able to reduce 3 shells, so the disease still has the upper hand by having a 70% likelihood of hurting you. So really, even though they're first-line agents that I'm talking about, they all have about a 30% annualized relapse rate reduction, so we still are not doing a great job in terms of trying to manage the disease. When we look at the Pedigree, which is the long-acting Avonex, it's the same precautions, same everything that I talked about, except the advantage of this is that product is that it can be administered every 2 weeks by a subcutaneous injection, which is underneath the skin for relapsing remitting MS. Due to some new pegylation process, it allows for a less frequent dosing, again allowing patients to have a less invasive type of injection less frequently. And again, it has an annualized relapse rate reduction of about 36%. So again, around the 30% mark in terms of efficacy, with the similar adverse reactions as stated with Avonex. When we look at interferon beta 1A, which is the other product, well known as beta-seron, or not beta-seron, but Rebif, this is a product that is given at 44 microgram dose subcutaneously 3 times a week. So you can see that this interferon product has to be administered more frequently than that of the Avonex or the Pedigree. Same type of injection problems and cautionary issues as Avonex. Nothing is different. The downside is that it has a neutralizing antibody production of 20 to 30%. So that means that it has 1 in 3 people may not respond to this drug, or 1 in 5 people may not respond to this drug because our body shut down its effectiveness. Also, with the use of this particular drug, we need to realize that this drug has to be used in caution with patients with existing underlying depression, and it can cause a lot of alopecia or hair loss associated with it. When we look at the interferon, third interferon, which is interferon beta-1b, that's the beta-seron product. The last one I spoke to you was a Rebif that you probably are familiar with. This one is even injected more frequently. It's every other day. Same precautions apply. Neutralizing antibody production, the same as the Rebif at 20 to 30%. And again, the overall efficacy of all of these products is about 30%. So it all really depends on how the frequency of administration and so forth, by which you may want to determine which product would be beneficial for treating your particular patients. Glatiramer acetate is an interesting drug because it's a synthetic polypeptide composed of naturally occurring amino acids. People aren't really sure how it works, but it does suppress Th1 activity. It has a lot of activity to actually promote the production of what's called BDNF, or brain-derived neurotrophic factor, that current research is showing that plays an integral role in helping repair or remyelinate the myelin that's being damaged. Again, the downside of this particular first-line treatment of the famous 4 first lines is that it has to be given by subcutaneous injection every day. It has an advantage. You don't need a titration for it. And unfortunately, about 10% of the patients get like a pseudo heart attack-like condition that can occur in the second or any subsequent injection later on following the administration of this particular drug. When they do go to the emergency room to get this checked out, they will show a normal EKG, so you do need to be aware that if a patient complains of this, they need to be checked out at the ER, but it is associated with this unusual side effect with this particular drug of glatiramer acetate, or otherwise known as Copaxone. Again, it has a slight less efficacy, just slightly under 30% in terms of reduction of annual relapse rate, but it has the advantage over all the interferons in that if you did develop any neutralizing antibodies to any of the interferons, you really can't switch to another interferon because the body is still going to provide a neutralizing antibodies to negate it. So if you ran a test and you put a person on an interferon that was neutralizing antibody positive, you're better off next to switch over to glatiramer acetate where there's no neutralizing antibodies present, so that you can stay within first-line treatments, but with some of the downsides that I'm indicating here in this particular slide. So when we look at these first-line agents, really the current treatments of first-line agents developed several years ago is not that great. We only got about a 30% success rate, which still leaves a huge market, I think, for improvement and research and development to try and get a better handle on this disease. So when we looked at the original immunomodulatory agents, we realized that none of these treatments, even the ones that I still will talk about, they're not a cure. At best, they have an efficacy rate of about 30%. They try to decrease the number and severity and duration of each of the attacks to increase the quality of life. And we're always struggling as clinicians and as patients to juggle the effects of neutralizing antibodies that we generate in our body that trying to negate the drug to the clinical efficacy of the drug. So we need to make sure that we're monitoring our patients for neutralizing antibodies and utilizing the switch between interferons to glutaminyl acetate if neutralizing antibodies do become a problem. So when we look at some of the new advancements, which I'm going to quickly walk you through in the next few minutes, of the new drugs that are on the market, these drugs are significantly more costly, or they're about $30,000 to $40,000 per year. Some of them are covered, some of them are not. And one of the first drugs I wanted to quickly go over is that of Tysabri or natalizumab. This particular drug that came out as a blockbuster drug, originally thought to be the blockbuster drug, had the advantage of a new mechanism of action in that it basically blocked the adhesion of these Th1 cells, inflammatory Th1 cells that were like cancer cells floating around in our blood, from ever adhering or docking or sticking to the blood-brain barrier. So if we kept the Th1 cells in our bloodstream and we didn't allow them to gain entry to the brain and spinal cord, then they could never get in and they couldn't damage the myelin coating that are in there. It also had the advantage in that it was given based on the other injections that I talked about, given as an IV infusion once per month, which seemed favorable to the patients. So its mechanism of action, by blocking the attachment of inflammatory activated Th1 cells from ever attaching to the blood-brain barrier, prevented those Th1 cells from getting into the brain and spinal cord, thereby preventing myelin damage. And it was indicated as monotherapy for the relapsing remitting course of the disease. Now it's generally recommended as probably your last resort, and I'll explain why. When we looked initially, there was three main trials when the drug came out: the Pharm trial, the Sentinel trial, where we added the Tysabri to Avonex, and then there's a Tysabri versus a placebo trial. So when we looked at the first trial, the Pharm trial, we were really excited because of the fact that it showed 70% effectiveness. In other words, if the disease had 10 shells to shoot, the original first-line agents only removed 3 of those shells. This was the first treatment that could remove 7 of those shells that could hurt our MS patients. So we were quite excited about that. And it also showed significant improvements in the neurological assessments through EDSS scoring. It reduced brain atrophy or shrinkage that I spoke about, and delayed cognitive function because there was less myelin damage occurring when the patients were being treated. Also, when we looked at MRI findings, there was significant improvement in gadolinium enhancing lesions, a reduction by 92%. Gadolinium is a dye that they add to an MRI that detects areas of new inflammation prior to demyelination or myelin damage. And so this drug, with a 70% efficacy rate, 92% improvement in MRI, everyone was ranting and raving that this is the best thing since sliced bread. And we also look at the neutralizing antibody production was like Avonex, around 6%, which was good. So our body didn't want to develop antibodies against its effectiveness. That meant that the drug could work better. So when we looked at it compared to the existing first-line agents, we thought initially that this was the drug of choice for the future. We made a significant advancement in terms of treatment of MS. So when we looked at the pre-market safety surveillance, everything looked fine. There was no major adverse reactions in the few treatment patients that where the drug was administered to. However, as more and more patients started to use it, patients developed, which is a commonplace word now, PML, or progressive multifocal leukoencephalopathy, which essentially means that the drug suppressed the inflammatory immune response so much that it caused the extreme immunosuppression to occur that allowed this JC virus to now start to rebuild and start to kill our patients associated with the drug treatment. And we found this out specifically in the Sentinel study, where the company at the time said, hey, if Avonex is 30% effective and Tysabri is 70% effective, if we put them together, we might have a cure. But in fact, you didn't result in the cure. It actually wound up in high mortality rates associated with it due to PML. So that was a mistake that occurred that actually resulted in a voluntary withdrawal of Tysabri in February 2005. It was reintroduced to the market in February 2007 with a lot more restrictions, not to be used any of these therapies that I'm talking about in combination with each other, so that people do not wind up getting PML that can lead to death. So when we first looked at this risk based on the Sentinel study, the company estimated was 1 to 1,000 risk of developing PML. The present estimated risk, as the drug has been used more into the market, is now 5 times that. That's more realistic. And again, despite this risk, patients still have, and physicians still have, when all other treatments are not working, you have this discussion of, although there's this risk of you being 5 out of 1,000 chance that you could develop PML, or you can still take the drug and utilize that drug, hoping to delay progression to increase your quality of life. Those discussions are between the patient and the physician, and those decisions are also in the same regard. So I mention this here just so that everybody can understand the decisions that have to go into treat or not to treat. And so basically in Manitoba, the drug is covered provided that all other agents have been trialed in before it, which then took us to a new era of treatment involving some of the oral drug treatments, such as fingolimod or Gilenya. And this particular drug was also thought to be a new blockbuster that come out as the first oral MS patient, no more injection, no more IV chairs and everything else. And this drug basically worked by blocking the release of these inflammatory activated Th1 cells from your lymph tissue into the blood. So if you block their release into the blood, they don't get into the blood, they can't proliferate and expand in the blood, and they don't adhere and stick to the blood-brain barrier, they don't cross into the central nervous system to a significant degree, and people get better. And so that was a general gist associated with this particular product. The other thing that was advantage is you just take 1 capsule once a day with or without food, which was very convenient. The Freedoms trial looked at the efficacy results and showed that there was about a 50% efficacy rate in terms of annualized relapse rate reduction. So it was better than the first-line injectable agents at that time, not as good as the 70% with the Tysabri. It delayed time to progression, as indicated here, to the first relapse or an attack. And it also had significant improvements in MRI reduction, about 55%. Again, not as good as the Tysabri, but better MRI reduction of lesions of myelin damage than we saw with the first-line agent injectables that I spoke of earlier. When they tried looking at higher dosages, the purpose of this experience is to show that when we went to a higher dosage, there was higher dropout rates because of more serious drug interactions or drug adverse reactions that occurred. And although they didn't recommend that you need to monitor liver function, all people, including patients, clinicians, realize that we now have to continue to monitor liver function in our patients to safeguard them against any potential liver side effects. But we do know as well from our experience, if we stop the drug, usually the liver restores itself in case there was any adverse reactions as well. Patients that want to become pregnant, male or female, that are wanting to have children, it's recommended that they, not only for this drug, but for all immunomodulatory drugs, are stopped at least 2 months prior to wanting to conceive if you're a male or female patient wanting to have children with your partner, to ensure that these drugs are cleared out of the system before you try to conceive to have a child. So when we looked at the overall safety of this particular Gilenya, the first oral medication that came out, dosed once a day, there was some concern because it could increase your blood pressure, it could affect your liver. Because of its immunosuppressive effects, it could affect your pneumonia or cause infections like pneumonia in the lungs you have to watch out for, and affect your vision issues through the causing of macular edema. So, but those were the main safety concerns that weren't, overbearing or threatening at this particular time. And we thought that we had a really good agent that was better than the injectables at the time, especially with the around 50% success rate or by reduction in annualized relapse rate reduction. So everything was going along quite well for this particular drug until yet again, as it was released into larger numbers of patients, this particular patient, a 49-year-old male, back in February 17, 2015, went on to develop PML, but they didn't die from it. So again, this new blockbuster oral drug that first came out also has its reservations and precautions in that it is also associated with the development of PML. When we look at other oral medications such as laquinimod, it's this agent I mentioned earlier is thought to promote myelin repair by increasing the production of brain-derived neurotrophic factor at the lesioned or damaged areas of myelin, and BDNF is known to promote that myelin repair or development of repair mechanisms there. It works predominantly by blocking the production of inflammatory Th1 cells and Th17 subsets of immune cells that drive the pathogenic process of MS. But because it only had an efficacy rate of 23% when tried to be marketed under Nerventra, this particular product failed to get full approval on the market. However, other oral agents such as teriflunomide or Aubagio was approved onto the market. This drug was instrumental because it stopped the production or proliferation of those cancerous inflammatory Th1 cells that are known to drive the myelin damage that occur. The advantage, it was again given orally, 7 or 14 milligrams once a day. Efficacy similar to that of the original first-line injectable drugs, about 35%. Similar side effect profile to the original injectable first-line agents, the hair loss, diarrhea, flu-like symptoms, things like that. But there was also a risk of tuberculosis, so we had to ensure that patients put on Aubagio are pre-tested for TB to make sure that there was no problems associated with that use in here. And to the best of my knowledge, I don't believe there's any cases of PML associated with the use of this particular drug. There's Tecfidera or dimethyl fumarate, which is also known as BG12. That's also another new oral product that was there that has been on the market now. It inhibits the production of these inflammatory Th1 cells like the first-line agents that I spoke of. It has a higher efficacy rate similar to that of Gilenya or fingolimod, which is good, and a good response to improving MRI lesions and reduction in neurological disability score. So basically, it is kind of moved into first place right now over that of Gilenya because of the risk of PML in terms of oral immunomodulatory drug with better efficacy than the original IMAs, injectable products for those that are suited for this type of an oral product. When we look at other particular medications that were and are in development, such as alemtuzumab or Lemtrada or Campath, that particular drug was developed to target CD52 receptors so that we could destroy these inflammatory Th1 cells that we know that are causing the disease of MS based on the pathology. The downside and the upside is that this drug is very potent. It requires just 2 courses a year. First course is 5 days intravenous. The second course is for 3 days, 12 months later. That's the good side in terms of compliance that people like about it. But the downside is that if you have a negative response to it, it's in your system for such a long time that makes it very difficult from a safety perspective to try and figure out what would happen if you didn't respond positively to the drug. It has a similar response rate to that of the Gilenya or the Tecfidera in terms of efficacy rate. So you have to balance out the risk versus benefits with the use of this particular drug based on its potency and side effects. So based on my book chapter, what I wanted to just walk you through is if you do get diagnosed with relapsing remitting MS and you're able to undergo treatments and you don't have any contraindications, breastfeeding, pregnant, things like that, you'll want to start on your interferons, the first-line treatment, or glatiramer. If you get a satisfactory response, you continue with it. If you don't, you switch between interferons unless you have developed neutralizing antibodies, which then you'd go directly to glatiramer acetate. If you get a satisfactory response in terms of relapse rates reduction in your patients, continue with that. If not, then you have to consider the other agents that I have walked you through today. There's also an agent, bacituzumab, that is under ongoing investigation. This particular product is targeting the CD40 receptor on antigen-presenting cells. In other words, it's blocking the ability of antigen-presenting cells to pick up foreign proteins that may look like myelin to activate T cells. By doing so, it will improve your overall prognosis because you're blocking the steps required to activate inflammatory Th1 cells. Because it's still under study, there's no optimal IV dosages have been established as of yet, and clinical trials are still ongoing in this regard. When we look at Zembrinta or daclizumab, that particular drug was on the market, approved in December 2016 in Canada, but I mention it in these final few slides because it was recently withdrawn as of a note that I received on March the 2nd by the manufacturers Biogen and AbbVie, because again, we have these side effects where with all the immunomodulatory agents that we always have to risk the risk-benefit and whether the high risk of mortality is worth the efficacy of some of these particular agents, but they don't plan, based on the press release, to reintroduce this drug back into the market. Other drugs that are ongoing investigation are rituximab. Again, that's targeting it's a monoclonal antibody that's given by IV, but it's targeting the destruction of the B cells that actually are responsible for making antibodies that are responsible for eating away the myelin coating. So that if the inflammatory T cells actually make it into the brain and spinal cord, and they try to activate B cells to generate antibodies to eat away the myelin, this drug blocks the ability of antibodies to eat away at the myelin. But again, there is PML risk associated with this type of IV drug infusion. Also, people have looked at a variety of hormone treatments simply because women that have been pregnant often feel the best they've ever been. Their MS has kind of subsided, so they felt that maybe with the fluctuation in hormone levels during pregnancy, we'd be able to mimic that. However, research has been unsuccessful in doing that no matter what. Stem cell transplants, we figured, well, maybe if we can reboot our immune system with stem cell transplants, that it would help. This would be more of a last resort of a choice because there's, again, risk of mortality and so forth associated with it, despite the fact that some of these stem cell transplants occurred in Ottawa, Toronto, Montreal. Again, it's a risk-benefit Again, if you were on your last opportunity, exhausted all other treatments, this may pose to be an option for you. Vitamin D, we're recommending everybody take at least 1,000 to 2,000 units of vitamin D per day because it does have some merit in terms of assisting patients with MS. We need more research in this area to figure out what it actually is doing and how it actually works through its antioxidant effects and so forth, but we need more definitive mechanism of action in around that. We all have heard of the chronic cerebral venous insufficiency, or CCSVI. Again, MS is an autoimmune disease, not a vascular disease, so this has been pretty much discredited as taking over for a cause of MS. So in conclusion of my entire talk, we have to realize that MS is an autoimmune disease. Relapsing remitting is the most prevalent form of the disease. We don't have any cure for it yet. We're making huge advancements in this area where clinical efficacy has ranged from 30% for the original immunomodulatory injectable drugs that I spoke of with the interferons and glatiramer acetate to 70% of that at Tysabri. We found some new oral medications are hovering around the efficacy rate of 50 to 65%. But again, they're not without the risk of PML associated with that, so we have to figure out that mixed bag or puzzle. And we also have to be aware that when we're giving proteins into our body, the development of neutralizing antibodies can be problematic because they will negate the beneficial effects of these very expensive drugs that we're trying to use in our patients to help increase their quality of life and reduce their overall annualized relapse rate reduction. So with that, I would like to thank everybody for their attentiveness over the long presentation, but I think it's comprehensive that covers a background on MS and some of the current treatment options. And with that, I'll turn it back over to Jillian to gather any questions that may have been resulted from this in the final few minutes.
Wonderful. Thank you so much, Dr. Namaka. And yes, it was very comprehensive. So a wealth of information you've provided today. I would like to open the forum up for questions. And just to remind people, you have two options in which to ask a question. You can type your question into the chat pod. And again, just a reminder that only Dr. Namaka and I can see the question you've posted, so it is anonymous, or at least anonymous among your fellow participants. And the other way would be to press *7 on your individual phone line, and that way you can ask over the phone. I do request that only those who intend to ask a question over the phone to unmute their line. I also want to take a moment to let you know that we have an MS navigator by the name of Dawn Young joining us today. And as an MS navigator, Dawn uses her knowledge and past experience as a community resources coordinator for the MS Society in Saskatchewan to help those affected by MS navigate the many resources available and enabling them to enhance their quality of life. So if you have questions specific to the services provided by the MS Society, then please feel free to ask questions to Dawn as well, and I can direct those accordingly. And finally, before we get started on the Q&A, I do want to just remind you that we will be posting some poll questions during this portion of the webinar. I invite you all to answer I think there's 5 questions or so before you leave the session. Your answers are anonymous, but they do help us tailor future webinars to meet your needs. So please, I encourage you to take part in those as we're going through the next remaining 18 minutes or so. And I see some of you have already started to respond, so thank you for that. Okay, so we're going to jump in here. First question. Okay. Dr. Namaka, can you speak to future DMT development that doesn't suppress the immune system?
I believe, I guess the best way to answer that is we still have to go back to that the disease is an autoimmune disease. We can't run from that. We can't fight from that. In terms of other ways to suppress without affecting the immune system, I guess if we can develop, the answer could be possibly, because when we look at spinal cord injury and so forth, we're trying to inject certain components or drugs into the area that's already been damaged within a timely manner in order to repair that damaged myelin and spinal cord, which it could also be repaired in MS. But that's still not going to fix the onslaught of the continual damage that the disease is going to keep doing. So it's only going to put a Band-Aid on it. So if we only focus on the myelin repair end, to answer yes to your question. So I really think that we still will have to focus on different ways to interrupt or interfere with this autoimmune response that becomes pathogenic to damaged myelin.
Thank you. And is there anyone on the phone? Did I hear someone on the phone that wanted to ask a question?
Yes. Good afternoon.
Good afternoon.
Yes.
Hello.
Yes.
Hello.
Good
Yes.
afternoon.
Good afternoon. We're calling in from Lifestyle Options in Leduc, Alberta. Is there any way we could get the notes of this meeting, as we have missed a portion of it because we missed the time zone?
Yeah. A copy of the slides are in the chat pod. I'll repost them again.
Okay. Thank you.
And also, I guess, Jillian, if I can just comment to that, this material that's presented here is a comprehensive summary of the written chapter, the new chapter that we put out in the book called Therapeutic Choices that you may have access at your institution.
Okay.
Great, thank you. And I just asked if you're done asking questions, just to put yourself back on mute by pressing *6.
Okay, thank you.
Thank you. So I'm going to continue on with some questions here that have come on through the chat pod. This question, and forgive me if I'm mispronouncing it, but is specific to fingolimod.
Fingolimod, yeah.
Fingolimod, okay. And so this person is asking that they have a colleague or resident, rather, in her late 60s, and she has had MS for over 30 years. And
yes.
Would fingolimod help in the circumstances?
Well, like I said, the drug does have merit. It also has a risk of PML that's come to light with the use of the drug, so there are those reservations. If the person is 60 years of age plus and had a relatively benign MS and they have not tried the first-line immunomodulatory injection agents, I'd probably suggest maybe using that first. Also, maybe looking at the, Tecfidera, maybe next, and then, looking at other oral agents that are not associated with PML that I've indicated until such time that her or his disease, has progressed beyond the efficacy provided by those other frontline agents. To jump right to Gilenia, I don't know enough about the person's condition or state or severity of the disease to warrant that. So I would just, approach that with caution.
Excellent, thank you. Moving on, is a person with other autoimmune diseases such as celiac or hypothyroidism at greater risk for developing MS?
I guess that I would say, in my best opinion, professional opinion, yes, because you already have shown for other diseases that you have an overactive immune system. And because a lot of the same mediators of inflammation, like TNF-alpha and inflammatory Th1 cells, are present in certain other types of diseases, you could be at an enhanced risk of developing a disease like MS compared to the general population if you have other autoimmune disorders. That's why when we do a workup, we are looking for markers such as thyroid stimulating hormone or C-reactive protein or ANA, other things that are markers of inflammation, so that we can try and rule out those. But if you have an underlying overactive autoimmune disorder, it may make you slightly more prone to develop MS. And if there's symptoms associated with that, you should actually definitely get that worked up.
Excellent. Okay, so keep going here. Some great questions coming in, so thank you. Are there any promising developments targeting remyelination remyelination that might be paired with current treatments?
We have our own neuro-immunology lab, and there's others around the world that are looking at remyelination, specifically involving brain-derived neurotrophic factor. Our lab has done extensive research looking at a disease called Rett syndrome, where there's a pathogenic molecule called MECP2, which is a fancy name, but the bottom line is that molecule in Rett syndrome, which is a neurological condition in children that cause myelin damage, is that particular marker is upregulated. So MECP2 is upregulated, that contributes to myelin damage by decreasing the overall production of brain-derived neurotrophic factor that's involved in myelin repair strategies. So we are currently, and others are looking at that pathway so that we can hopefully check it out, and we've published some papers showing the elevation of MECP2 in patients with MS that lead to myelin damage by suppressing BDNF that helps with fixing the myelin. So if we can block that pathway, it would allow more BDNF to be around so that we could therefore be in a better position to try and help remyelinate that area of damage.
Thank you. An interesting question that's brought forward that I'm curious to hear your response to, Dr. Namaka, and that is, how do you think pharmacy can work better with physicians to better help patients in terms of medication access and side effect monitoring?
Well, pharmacy, I think, has a very key role in managing MS patients. I think that the pharmacists are talking quite frequently and are more accessible sometimes to MS patients, so they can look at culling out, by communicating with patients an attack or an MS attack, that just by normal consultation, hey, since your last refill, have you had any attacks? Have you had any major deficits that last more than 24 hours that were separated by 30 days? That simple line of questioning, and then subsequent faxing or reporting to the doctor, those type of things, FYI, may help in terms of changing treatment, continuing the current treatment, increasing dose, that could actually help overall the course of managing the disease and quality of life for patients. So I think they're, in my professional opinion, a much underutilized resource that could have more impact by spending more time, again, counseling and talking to patients to figure out, how the patients are actually doing, and the different symptoms that patients may think are a symptom may actually be an attack, and by being in better, frontline communication with the physician, the primary physicians that's monitoring the disease, more people working on the page that's looking at attack frequency and severity and so forth, I think the better off that we're going to be for the patients that have the disease.
Well said. I think, I'm receiving a few questions that I'm going to paraphrase, so bear with me. But we all are looking for ways in which that we can be proactive and take a bit of control, I think, in what's happening when you're experiencing a diagnosis of MS. And some of the questions that I've been receiving ask about your thoughts on the role both diet and exercise can play in terms of how they change the course of this progressive disease, the progression itself, how it may interact or have contraindications with other medications. Can you speak to that, the role of diet and exercise in combination with the pharmaceutical?
Yes. So, diet and exercise are also good, but you have to realize that with exercise, you have to, if you're a person with MS, you're going to be fatigued more often because you're losing the electrical signaling from point A to point B outside of these eroded areas of myelin along the nerve axons that allow us to function and exercise. So we don't want to push our exercise to the point that we're, really, really exhausted. If you normally, for example, ran a mile a day, you may want to, run shorter distances more often throughout the day to get your mile of exercise in rather than push the whole mile right now, because then it will take you 3 times as long or more to recover from pushing on that exercise. So exercise is good, but it has to be broken up into more smaller digestible pieces. From the diet perspective, I think the diet of eating, healthy foods, good antioxidants, vitamin E, vitamin D, those type of things are very critical, because we're learning more and more that vitamins like vitamin D and its antioxidant properties and maybe other properties that have not been fully established do have a benefit in terms of helping slow the disease or the inflammatory cascade of the immune cells, by which mechanisms we still don't know how that occurs. So I do believe strongly that diet and exercise is good. It's good for the mental well-being, physical well-being. It's better than just sitting around where you can run the risk of other complications secondary to MS due to immobility. And if you're able to work with physio and set up a diet, an exercise plan, even aquasizes is really good, because it takes the stress off of a lot of your major muscle groups or joints, and it allows you to exercise without having your body weight to actually fight because of the buoyancy associated with swimming. So we often recommend some of our patients go into the aquasize program as well.
And in keeping with this theme of sort of being proactive and doing what we can, another question came about with respect to OTC supplements, so over-the-counter supplements. Do you have any suggestions that people can take in conjunction with the pharmacological strategies?
Well, again, there's a lot of over-the-counter supplements. It depends on what we're talking about. If there's things like vitamin D or E, I would say you can use them. If there's a lot of other unusual herbals and stuff that may be there, we don't have enough information on some of those to determine whether they interact with the current medications they're using, whether they're beneficial, whether they can cause other comorbidities or problems associated with their use. There's also problems with some of the natural products in that they're not regulated the same way that a pharmaceutical product is that from brand to brand or whatever, that we don't know exactly the actual content of the active ingredient that we're maybe looking for. So there's a few unknowns, and I think that through time, as the natural product industry starts to increase the regulation of the product so that we know more what's in it, exactly the active ingredients in it, and maybe make them more accountable to run some trials for their claims that they're able to put for people that are ingesting. It's just that, a lot of people don't know, certain drug interactions or drug disease interactions with these herbal products and their conventional medicine they're using that can create more harm sometimes than good. So I exercise extreme caution, because if those things were all, perfectly efficacious and safe, that everyone would be using them, including the pharmaceutical companies that are looking at treatment management and symptomatic management.
Excellent points. Okay, so we're about 3 minutes shy before we're done to conclude here, and I know that there's a lot of questions coming in. I'm doing my best to get to the ones that I think will be the most applicable to as many of the participants as possible, so bear with me. I realize the irony of that when I have a poll up asking whether questions are answered, but we will move forward. This one is about pregnancy. So you spoke to a couple of the medications that you suggested where both prospective father or mother be cleared of their medications before conceiving a child. Are there any treatments presented that are safe for pregnancy? And if someone discontinues a medication when they're attempting to conceive, what risks are there?
Well, with pregnancy, again, the jury's out. We know that these medications affect your immune system, and in a developing child, everything is just developing. So they would all have impact. To the exact degree, I'm not sure that everybody knows the exact degree, But we do know that based on the half-lives and clearance of the drugs, the immunomodulatory drugs that people use, if you, a lady or a man decides that, hey, they want to embark on having a child, we're recommending that at least a 2 to 3 month washout period of all medications before trying to conceive, because it can affect, that reproduction process. And we don't want to get it affecting the reproduction process right at the first cellular event when conception occurs. So we're trying to do our best or due diligence in that. If you're saying, is there a drug product that I can take while I'm having MS and it's not going to pose any risk in pregnancy, it's not there. Not that I'm aware of or that I would recommend, but that's my own personal view than what I know. But I do know that when women, for example, do become pregnant, their MS, in the majority of cases, subside. And the risk of passing MS on to the developing child is about 5% higher than the general population, which is 20 to 40 times higher than the general population. So that's a decision that has to be made between the person that's wanting to conceive a child and their spouse to determine if they are willing to take that risk. The also decision in that regard is that after you have the baby as a woman, your body goes through a lot of trauma. And that trauma leads to injury and inflammation. And if that inflammation happens to activate or reactivate your MS, you may not be able to look after the child because you'll be in the middle of an attack right after your childbirth, which we have seen as well. So you have to be careful on the risk-benefit and make sure you have the proper support structures. Should that attack occur after you have a baby, you make sure that somebody is there as well to help care for that baby, because those are realistic risks on those two regards or domains that I just wanted to mention.
Thank you very much. Very poignant advice. Okay, folks, we're at 2:30 here in Ontario, which means that we've come to the conclusion of our webinar today. I know that we could probably go on for another hour or so given some of the wonderful questions that have been provided. So apologies to those that we just simply didn't have time to get to. I do want to thank everyone for their participation. It always makes for such a great event when we have this type of interaction. And of course, Dr. Namaka, thank you so much for your time today. There's a lot of work that goes on to these webinars behind the scenes well in advance of the actual presentation day. So thank you so much for dedicating your time and resources to today's webinar. Two reminders, before we go. A recording of this webinar will be available on both the MS Society of Canada's website and Brain Exchange's website within the next few days. So if you're looking for that, you'll be able to find it there. All participants and registrants will receive notice that the recording is available. And then secondly, you will also be receiving an email very soon, today, within the next hour, requesting your participation in a survey from MS Canada. So please keep an eye on that in your inboxes. I would like to invite my colleague from MS Society of Canada, the Manitoba Division, Daryl Hawanuk. Daryl, are you there to say a few final words? Just to remind you, Daryl, it's *7 to unmute. Daryl, are you there?
Hi, Jillian.
Hi, there you are. Perfect.
On behalf of the MS Society Manitoba Division, I wish to thank our esteemed speaker, Dr. Michael Namaka, for broadening our understanding on the therapeutic management of MS. And I'd also like to thank everyone for joining us on this highly informative session presented by Dr. Namaka, and wish everyone a great day. Thank you.
Thanks, Daryl. And again, my thanks to you, Dr. Namaka, as well. And thanks to everyone for participating. We'll be doing this again next month, so have a look for that. And until then, have a great day, everyone. Take care. Bye-bye.
Bye-bye.